the way that we have this webinar organized is a bit of an introduction, and then each of our 3 speakers will give about a 15-minute presentation, and then there'll be time at the end for questions and answers. So I'm Heather Whitson. I'm at Duke University, and I organize this webinar series along with Leah Hanson, who is at HealthPartners. And we want to extend thanks to the other members of the webinar work group, include Kumar Damarajan, Heidi Kleppen, Stephen Waring, and Jane Szynski. And a thanks to Catherine Anzuni and Joanne Wagner, whose administrative efforts are making all this possible. So the webinar series is sponsored by an NIH-supported initiative, which is called the Advancing Geriatric Infrastructure and Network Growth, or AGING Initiative. The initiative is led by Drs. Jerry Gerwitz, Elizabeth Bayless, and Jay Magaziner, and includes investigators from the Healthcare Systems Research Network, which was formerly called HMO Research Network, and also investigators from the Claude D. Pepper Older American Independent Centers, or the Pepper Centers. So the goal of the AGING Initiative is to bridge together these 2 powerhouses of geriatric research and data to create a national resource that would nurture and advance interdisciplinary research focused on older adults with multiple chronic conditions. So this webinar series serves one of the initiative's aims, which is to disseminate interdisciplinary research approaches and findings that are relevant to the science of MCCs, and share that with the larger scientific community. So that's what we're doing today. Before we move on to the scientific content, I was going to say a few words about the webinar software, which you can tell sometimes presents challenges. So due to the level of interest in today's webinar and the number of lines that we have active today, we will not be using the hand raise function in the software. I'll absolutely encourage you to submit questions for our speakers. To do so, please use the Q&A function. So for those of you who are signed into the webinar and viewing the in front of you, what you should see is a panel on the right side, just to the right of the slides. And on that panel, there are several different tabs that you can choose. One is chat and one is Q&A. So if you want to submit questions, please just select the Q&A or the drop down, and you can type it directly into the box, and then we'll read your question for the panelists at the end. In addition, several people did submit questions when you registered, and we'll also be reading those questions at the end for the 3 presentations. So without further delay, I'm going to go ahead and introduce our first speaker, Dr. Mary Charlson. So Dr. Charlson is the Executive Director of the Center for Integrative Medicine, as well as the Chief of the Division of Clinical Epidemiology at Weill Medical College of Cornell University and Newark Presbyterian Hospital. Dr. Charlson developed the original Charlson Comorbidity Index in 1987 and has recently enhanced it to predict costs and hospitalizations. In addition to her pioneering work on multimorbidity measurement, Dr. Charlson has designed clinical trials of mind-body interventions as well as behavioral interventions and has developed new measures of other clinical phenomenon. It is a pleasure to have her speaking to us today, and I hope that she is still connected. Dr. Charlson?
Hi, can you hear me?
Great. Take it away. Yes.
Could you use the slide presentation, please? What I want to talk about today is comorbidity. Why? Next slide, please. Next slide. We're supposed to talk about is multimorbidity, but then is what is it? And the reason I ask that question is that it's defined very differently in different places. So some people include functional measures in terms of activities of daily living or functional limitations. Other include serious mental illness. Some include frailty. Some people who falls. The problem is, given the term is used by many different people to mean many different things, the prevalence of multimorbidity range from 17% to 71% in studies. So get away from that term because it is so many different kinds of things, and that have been written about it, therefore cover a variety of different things. But what I'm going to talk about is comorbidity. Next. And I knew that Cornell University has filed a patent for the use of the Enhanced Comorbidity Index to predict future costs. Okay, we can begin with the original Comorbidity Index. So it was designed to predict the diagnostic burden of chronic disease and to predict mortality, so that you could use it as a measure to control for confounding of other chronic diseases in studying a single chronic disease. The idea was that it would avoid the population. So if you're seeing hypertension, you wanted to maintain the patients with cardiovascular disease and diabetes and cancer in it, but you had to be able to control for the impact of other chronic diseases on the disease that you're studying. It was developed in medical patients, and where the target was 1-year mortality, and the validation population published in the original paper was an equivalent number of breast cancer patients with 10-year mortality. Next slide, please. This is the original comorbidity index with the weights for each of the chronic diseases that was initially included. And then has been used in a number of different publications. Next slide, please. So with higher comorbidity have worse physical and mental health, greater disability, higher morbidity and mortality, and higher hospitalization and readmission rates. And the results have been cited in over 13,000 different publications. People found it useful in our regard. So what I'm going to talk to you about is why comorbidity is now key to we're entering the era of population health management. Next slide, please. Next. And I'll share with you data that we published in PLS1 last year on 181,000 healthcare workers and their families. So, and I'm going to use that the comorbidity index can be used to cost hospitalization and readmission. Next slide, please. Healthcare costs rise steadily with increasing comorbidity. So as comorbidity ranks go from 0 to 12 or more, you can see a steep increase in the average annual costs. And this is comorbidity from 1 year predicting costs in the subsequent year. Next slide, please. It shows you that in this employed population, a relatively low percent of patients have high comorbidity. So only 1.1% had a comorbidity score greater than 8. The vast majority of patients had a comorbidity score of 0 or 1. Next slide, please. Hospitalization rates rise steadily with increasing comorbidity, and it's the hospitalizations that are driving increased costs. No one's surprised. Next slide, please. Hospitalization also steadily increases with increasing comorbidity. So you can see in red are displayed the proportion of patients or beneficiaries with 3 or more hospitalizations subsequent year. So it's only hospitalizations per se, but also repeated hospitalizations. Next slide, please. This summarizes the percent of beneficiaries and costs. The beneficiaries are in blue and costs are in red. So you see that a relatively small proportion of beneficiaries with a comorbidity score greater than 4 are driving a significant proportion of the costs. It's about 16% of patients with a comorbidity score of 4 or more account for 26 to 30% of all the costs. Next slide, please. Surprisingly, as you would expect, costs according to comorbidity and number of hospitalizations. This drives home the point that, in fact, it's the number of hospitalizations that is the predominant driver of cost. Next slide. As a principal driver of cost, the average hospitalization costs are $25,000 to $1,000. And the patients for high comorbidity have the greatest potential for cost reduction by reducing hospitalizations. Slide, please. So this is going to show you how the comorbidity index compared predictor versus prior year comorbidity, DCG score, that's the 2009 prospective DCG score, and prior hospitalizations. And we compared it using different kinds of statistical methods, which give a different kind of view of the data. Next slide, please. Shows you a two-stage regression model in which the large amounts of patients with zero costs were modeled in one step of the regression, and the rest was modeled. Control age, gender, and mental health diagnoses that prior year costs do have higher R squared in terms of the ability to predict future costs than comorbidity and DCG, which are about equivalent in adults. And prior year hospitalization is a less accurate predictor. And you can rank in children as well. Next slide. So look at quantile regression, that is, predictors of the adults and children who'd had the top 5% of the costs. And here, an equivalent statistic, pseudo R squared, you can add the major difference is that prior hospitalizations performs much more poorly than either cause, comorbidity or DCG. Next slide, please. To the top 10% of costs, once more prior hospitalization, the off on this prior cost should be on the first line. I get moved. The spacing got lost, but prior hospitalization is a much predictor of the top percent of costs. Next. And do the same, you can look at the area under the ROC curve for the top 5% and 10% of costs in adults and children. And once again, you see that prior year costs, comorbidity, DCG are fairly equivalent. Next slide, please. So one of the conundrums that we face is that in most of the literature that's been published, disease management programs, whether it be Medicare demonstration projects, and coordinated care, case management programs, and I'm not going to name them all by name, but if you look at the literature, most of them have not reduced costs. And the reason they haven't reduced costs is for the most part, they have reduced hospitalization. And what's happening is if you get the wrong patients, you end up spending more than you save. And I think that's what's happened with a lot of the efforts today. Next slide. So this just shows you the total cost. This really is the story of why disease management structurally can't work. So it shows you the total cost for specific diseases according to the adjusted comorbidity index. And what the adjusted comorbidity index does is if you have that disease and that disease only, it factors out the weight of that disease. So if you've got so people with a comorbidity score of 0 have that disease and that disease only, whether it's cancer, congestive heart failure, stroke, asthma, COPD. And what we see is that when taking into account what's driving aggregate costs, it's the aggregate burden of comorbidity, not so any specific disease. Next. But the next shows you why the disease management program is able to effectively target the people who are having the cost, because most patients have a single disease or perhaps two chronic diseases. They don't have a high burden of chronic disease. So this shows you the percent of patients according to adjusted comorbidity score. The majority of patients are falling on the left side with an adjusted comorbidity index of 0, 1, too, but the highest costs, where you see the exponential rise, are increase for the Comorbidity score of 4. Next, please. So things that we've done is we've kind of decided, I'm shifting a little bit now, but we've made the determination that we should have the same protocol or the guidelines or the same hemoglobin A1C or blood pressure target for all patients. That's probably true in geriatrics, where there's more of a view of the whole person and keeping them functional. That assumption is based on the reducing variability in process will improve outcomes. But for those with a high burden of comorbidity, this probably is not right. Next slide, please. So we've got 3 patients, all 75-year-old men, MI, scheduled for colorectal surgery. Their labs are the same. Their anesthesia scores are the same. By industrial process assessment, they're the same. But by assessment, are their risks the same? And why are you more worried about the recent widower? So we've taken the calls and apply them broadly, and that's fine for answering phones, make sure you operate on the right side of the bus, but to make the same level of an A1C in a 75-year-old with type 2 diabetes, where the risk of making them ischemic, we're probably not doing the best that we can for patients. Next slide, please. So what is the theory that industrial processing rules that result in less than 1 in a million errors in manufacturing light bulbs apply to patient care? But in reality, next please, patient variability is the driver of outcomes. And I think we have to look at stepping from using the usual metrics of blood pressure and hemoglobin A1C and the usual kinds of measures of process in patients who have a burden of comorbidity or multiple chronic disease. If the people taking care of them look like they're not meeting standards, because if you try to reach the you're not working in the best interest of your patient. Next slide, please. We really need to think about different, for the patients with high comorbidity, we need to think about different outcome metrics. Separate this group of patients from the quality reports that have been the norm, starting with us, but moving to other areas into a mandated reporting. So last slide, you want to just move to the last slide. So the thing I wanted to point out is that the comorbidity score can test in 5 minutes, either with having a patient fill out a web form or a questionnaire or interview administered. It can also be assessed from medical records, registries, repositories, as well as from claims data. I think that's actually the last slide.
Thank you, Charlson. That was outstanding. And Leah, are you on?
Can you hear?
Are you? Hopefully everyone else can too. I'm going to let you enter next speaker.
Thank you much. It is a pleasure to introduce Dr. Arlene Ash. Dr. Ash was a lead developer of the DCG HCC models adapted by Medicare and other federal agencies to pay health plans to care for members based on their morbidity profiles. She founded a company, now V-Risk Health, that further develops and disseminates these models that capture the effect of multiple morbidities on many outcomes, both clinical and financial. She is a professor and division chief for biostatistics and health services research at the University of Massachusetts Medical School. Dr. have Dr. Ash on the line.
Just now we couldn't hear you, so you might need to manually unmute your line by clicking on the little microphone icon beside your name. Dr. Ash earlier, so working on getting Dr. Ash connected, and Dr. Ash, if you join us, just speak her up. In the meantime, we could take one of the questions that was submitted.
That's a good idea. So we received some questions in advance, and let's start with the question, what are ways to measure polypharmacy for individuals with multiple chronic conditions? And Dawson, do you want to take that first if you had a response?
A really good question. I think and truly I don't have a response on the top of tongue, but
that's
I just don't. But some line may have a response.
Dr. Elixhauser, are you with us? Do you address the issue of polypharmacy?
Hi, can you hear me?
Yes.
Oh, thank goodness. It's the first time I've been heard yet. Okay, so, I have never used pharmacy data, so I can just sort of conjecture off the top of my head if we want to go there. I could imagine a way of classifying medications by condition. So use some of the existing classification systems like within our group, the HCUP group, the Healthcare Cost Utilization Project. We have something called the Clinical Classification Software, the CCS, which basically groups conditions into the clinically homogeneous categories, and like diabetes, hypertension, et cetera, and at how the drugs fall into those categories. That assumes that you're able to make a relationship between the drug given and a condition. Assuming that you're able to do that, you can then look at how the drugs fall into these various categories within the CCS, or the Clinical Classification Software. We have about 260 different categories. I'm sure there's other categorization schemes that could be used as well. I've not read about it either, so this is a guess on my part.
One to say that I think that you did very well with that, Anne. I think what complexities is one of the concerns that we have is, with the new sprint recommendations and people being treated with multi-antihypertensive drugs and two diabetics getting treated with insulin as well as oral hypoglycemics, that part of the problem of polypharmacy is going to be drugs from the same sort of group.
Yeah, no, I think you're right. I think what this calls for is a new classification system. Maybe you could work on that.
We just one more question. There was a question specific to looking at a population of cancer patients. Could you talk about each of your methods and how do you see them being applied to cancer patients, or do you believe that a cohort-specific index would need to be evaluated or to be created in order to evaluate the burden or comorbidity along with
This is Mary Charlson. So cancer is part of the Comorbidity Index, and everybody, if got breast cancer patients, they'll all start out with a given score. Difficulty with condition-specific indices is that pretty soon you have so many specific indices that you lose utility of a measure that it can be applied to different populations. So you can't compare the experience of this group of breast cancer patients with this group of lymphoma patients, and it's going to make it harder to interpret what's happening in aggregate populations. That's wrong with the condition-specific scales.
Arlene? We also found that condition-specific rarely is substantially more powerful for almost any question that you want to ask. Have captured most of the morbidities. You really have a fairly robust measure of people's vulnerability to various outcomes.
I agree with that. I think something that you'll see is that whenever people develop indices specifically for a patient population, your C statistic will go up a little bit, but I don't know how meaningful that is. And I think that what that is really important, that it is really good to be able to apply the same tool across populations to see how various populations are functioning under different circumstances.
Well, so glad we can hear your voice. Welcome to the conversation. Sorry about the technical difficulties. Would love to jump right into your presentations. Your title slide is on the WebEx. Why don't you go ahead?
Okay, so I would like you to know that I see event information and I don't see the titles. Oh, got it. All right. Okay, we're all on the same page now. Great. So people have had a chance to look at my information, and you spoke about who I was. Why don't we go to the next slide? And so I just thought I would introduce myself a bit. I've been doing risk modeling since 1984, and something very important to understand is the DCG score is a family of models. It's a modeling enterprise and a suite of tools that have been under development since 1984. So originally there were contracts with the federal government, with the agency now called the Center for Medicare and Medicaid Services, to develop models for them. And so they were in Medicare population. They were designed for payment in what we now call the Medicare Advantage program. But there are many, many DCG models. So when someone tells you that they used a DCG score or a DCG model, you really have to ask them, what are you talking about? And my presentation will show you the various kinds of questions that you would ask. So I would like sort of full disclosure to say that that I was a founder of a company now called Verisk Health that markets a suite of DCG products, and in order to differentiate them from the publicly available family of models, we call them DXCG. So you see the X in there, you're talking about something that is part of this long research that branched off from the publicly stuff that we developed a long time ago. One other thing about me is that I believe, just as Mary said, that there's many, many things that we don't capture necessarily in a simple morbidity score that are really important for understanding how much people will cost, what outcomes you can reasonably expect with them when they go home after a heart attack, and all kinds of things that we like to measure, where we like to attribute some blame or credit to an entity that's treating that person. And right now I'm very involved in a social determinants of health project with the state of Massachusetts to take the very best DCG models that we have, which are all only measure age, sex, and morbidities, a morbidity profile, a very rich morbidity profile, but we're adding to that information about poverty, instability, and other factors. So, next slide. This is just to give you the flavor for where we're going. There's going to be a slide talking about this DCG chronology. I'm going to pass over it very quickly. Partly it's there so that you'll have it as part of the record, just as at the end of my slides there's a set of references, so you'll have them as part of the record. I'll also talk about two very different reasons that one might want to have a morbidity tool, morbidity software, and one is serving the grouper function, and the other one is serving the modeling function, and I'll talk about those different functions and how we deal with them. And then I want to talk about strengths and limitations of the whole family of models, and you might say the two families of models, the ones that are publicly available and the ones that you can get through licensing from the company Verisk Health. Next slide. As I said, this modeling began actually in 1984 and led by the year 2000 to becoming the basis for the first models that the federal government used to make payments to health plans who were signing risk contracts for taking care of Medicare beneficiaries. And somewhere around the end of 1996, we did found a company to continue to update and expand on and refine the models that we had delivered to the federal government. And so there became sort of two classes of models, the ones now called CMS HCC models and the DCG AC models. One is maintained and expanded for different uses by the federal government, and the other one by Verisk Health. I'll spend a moment talking about what the HCC is. Let me just map the words right now. Hierarchical condition categories, and in future slides I'll explain why the word hierarchy is in there and what the condition categories are. Next. So, the first to say is that these models actually are most powerful and most appropriately used with claims data. They were designed to be used with claims data, and they were designed to take advantage of the rich information available in claims data, so that you wouldn't have to just classify a person by one or two things that were problems that they were having, that you wouldn't have to classify them in a very broad way as someone who has or doesn't have a heart problem, that you could actually identify the particular heart problems that someone has and the particular problems that they have if they have respiratory problems. And so they can be used, people have tried to use them with simpler data, with data that has been collected in different ways, but they're nowhere near as a real value is in terms of their ability to really capture the breadth and depth of information available in claims data about all the medical problems that someone has been seen for during a defined period of time, usually a year. So the morbidities are collected, have been using ICD-9 codes. The models were developed years ago for use nationally with ICD-10 codes, so they're ready for use with either kinds of coding. And they use the data to summarize the information and first of all come up with a judgment based on all those ICD-9 codes of which morbidities are present or not. And then there are a family of models that are used to predict various outcomes as a function of age, sex, and this morbidity profile that's constructed. And I just threw down a short list of different things that models have been used to predict. And the point is that while their history is that they were used to predict next year's costs using Medicare data in a Medicare population, they in fact have been used to predict costs, to predict mortality, to predict readmission, to predict the likelihood of an emergency department visit in the next 6 months, the likelihood of readmission within 30 days. They're very powerful models, and there's a very broad suite of models that predict different outcomes. Usually the output of a modeling exercise is a relative risk score, so that if a person gets a 1, it means that they will have the expected outcome they will get is average. And 5 means 50% more than average for any continuous variable like cost or number of something that might be happening. Okay, slide. If you have worked with ICD-9 codes or ICD-10 codes, you will realize that they are much too fine and detailed and elaborated to actually be useful in defining coherent clinical conditions. There are at least 14,000 ICD-9 codes, and there will be something more like 68,000 ICD-10 codes. So the concept was to provide a method of grouping those codes and to be able to create a vector of yes-no markers as to what conditions were present. And the DXCG mapping maps to 374 CCs. It's comprehensive. The MS model actually uses only a small fraction of the codes and only retains 80 CCs, things that it considers to be important and worth paying more for. I think, Mary and I weren't sure, we had a brief conversation by email before this call, that she may be using the CMS version of the HCCs. Okay, so where does the word hierarchy come in? If a person has a cold and they also have very serious lung disease, then the hierarchy says we zero out the information about a cold. That's not so interesting. And that enables us to build models where a person who has merely a cold is not confused with a person who has a cold on the way to being found out that they have very serious diseases. Okay, the risk scores are used as benchmarks, as predictions. Moving to the next slide. Very simple mock-up slide here. If you were looking at a set of doctors and asking which one spends the most money per patient, you would perhaps have a very different answer to that question if you were looking at the dollars spent per patient versus a normalized, a risk-adjusted dollar spent per patient. So this slide you see that Dr. D looks like a very expensive provider and A looks like a very efficient provider, but if you go to the next slide and you look at the ratio of actual costs to expected costs, that Dr. D had very high expected costs and so came in fact looking fairly efficient. And so things move around when you understand that some people's profiles are very much than others. Okay, moving to the next slide. So as I said, the inputs are age, sex, and diagnoses. The models are complex. They have they must be fit to huge databases, which is why their greatest value is when you have a model that was fit to a very large database. The coefficients were fit on that very large database, but you can apply it on a very small database, and it will take care of a little bit of extra risk for each little extra thing present. You don't have to simplify the model in order to use it in a very small data set as long as you have claims data. And they're very sophisticated modeling strategies used to address all the problems that occur in trying to predict costs, where there are some very influential outliers, or in trying to deal with the fact that some people are present for only half a year and their costs and or what medical problems you see might be different because of that. Also, we don't just say that a person has asthma. We separately model the asthma for a child or the asthma for an adult. So there's a great deal of attention paid to the difference in the costs for children and the costs for people in various age groups. And furthermore, as part of the classification system, each of the CCs is labeled as chronic or acute. That again, as part of that grouper function of helping you understand which people have chronic problems, which ones have acute problems, the grouper function is helpful there. Next slide. So modeling is fairly simple. You just accrue risk, use some basic intercept, which I'm not going to talk about. You have this these risk indicators times risk weight. There's a certain amount of risk added for each thing that you find. More risk added for having congestive heart failure than for having hypertension. Let's move on. Next slide. And fundamentally, it's an additive formula, although there's a lot of extra work associated with making sure that the addition comes out right within subgroups defined by age and other factors. And the more morbidities you have, the higher the risk score. And when there are multiple morbidities, there's an adjuster to typically add extra risk associated with, you have these two serious diseases. The net cost, the net complexity of the person having those two is greater than the sum of what you get for either one of them alone. Next slide. Just looking at a profile for a person during the year, they spent a certain amount of money. They saw the healthcare system. There were certain dollars associated with that. The model doesn't pay any attention to the dollars. The model uses the person's encounters with the healthcare system to create a morbidity profile and to give you a score saying, oh, because this is a 60-year-old male who had these particular medical problems, we think that their costs will be 11 times greater than another person. Next. So what are limitations of the model? That you do have to have claims and enrollment data. If you're dealing with people in a system where every little thing is coded, there will be some inflation in the risk score, although we've tried to has worked very hard to eliminate that, to minimize that. And so, for instance, you don't get extra credit because you wrote down the person also has a cough as well as their serious chronic lung disease. And you don't get more credit if you wrote it down twice or 5 times during a year. And you don't get more credit if the problem was seen in the hospital versus seen outside. We're trying to get a pure morbidity profile. The models have to be fit to large databases, although they can be used on small ones. And you have two choices. One of them is to use public models, which have something like 80 condition categories, focus on categories that are of greater interest to older populations, although not exclusively, and they're simplified. You can't get the full richness of the DXCG models. And the DXCG models require licensing. It's a proprietary product, but the good news is that there's very modest licensing costs for researchers. And of course, like all morbidity systems we're talking about, they don't yet incorporate any factors other than the medical problems that are captured. Next slide. So this is basically the last slide. There's one more, which is references. I won't spend any time on that. Strength of the model is they can be used to predict just about anything, and they have been used. They've been around a long time, and there's lots of stuff in the literature about the variety of things other than costs, as they've been used to predict. They have been tested by the Society of Actuaries, by a lot of people not connected with our research group, and found to be extremely highly predictive. We have found them, going back to Mary's comment about the question about, do you think there should be we should have specialized morbidity measures? They've been found to be very predictive in subpopulations. They work very well, developed in one place, applied in another place, applied 5 years later. They're robust. They're very helpful. It's easy to use them to add risk factors. It's easy to say, I will put into my model the risk score, which is a rolled up summary of all that morbidity information. I'll put in the person's age and sex, and I'll add other risk factors like how poor is the person? Do they speak English? Have you moved at least 3 times in the last year? The classification system creates a very, very robust, helpful grouper because it's comprehensive and clinically rich. As I said, it's available for researchers.
Thank you much, Dr. Ash, for that presentation. We are going to move right along to our next presentation. Do continue to submit your questions using the question and answer at the bottom right hand of the panel. It's now my pleasure to introduce Dr. Ann Elixhauser. Dr. Elixhauser is a senior research scientist with the Agency for Healthcare Research and Quality. She works on the development of hospital administration databases and tools for the use with this data, including quality measures, diagnosis, and procedure classification tools and applications. Has conducted research on children's use of services, disease cost-effective analysis, measurement of comorbidities, and merging clinical and administrative data, among other topics. Her work has appeared in the Journal of American Medical Association, Lancet, Pediatric Health Affairs, Journal on Quality and Patient Safety, Mortality Weekly Report, Journal of Health Policy, Medical Care, Diabetes Care, Services Research, and Health Economics. It's a pleasure to introduce Dr. Elixhauser. I will pass the baton to you.
Okay, thank you very much. Can you hear me all right?
Yes.
Oh, that's great. Okay. So next slide. First thing I would like to do is to acknowledge my co-authors who have worked on a couple of papers with me. The first one was the original paper that we did back in 1998. And then right now I'm working with a group of people where we're being on that original comorbidity work to develop indices for looking at in-hospital mortality and readmissions. I'm going to be presenting a little bit of that information, but it's in right now, so I don't have a whole lot of information from that yet. All the folks that you see here are primarily involved in the Healthcare Cost and Utilization Project, or HCUP. It's a data project at the Agency for Healthcare Research and Quality. And what HCUP is basically administrative billing data. We take bills that are sent from facilities to the insurers, or in the case of uninsured patients, directly to the patients. We have a partnership right now with 47 states and the District of Columbia to get all of their hospital inpatient data, and we convert that into a uniform format. We make many of those state databases publicly available for purchase. And we also create a number of national databases derived from the state data. We have a national inpatient sample, the National Emergency Department sample, and our newest data product is being released just this week. It's a nationwide readmissions database from a subset of states that actually provide us with patient identifiers so that you can look at readmissions and revisits across the inpatient setting, the emergency department setting, and ambulatory surgery, and you can make national weighted estimates on that. The data that I'm going to be presenting later uses this nationwide readmissions database. If you're interested in any of these data, I spend more of my time working on the data than on research, but if anybody's interested in looking into these data, please feel free to contact me. I'm sure you can contact me through the webinar organizers. And you can also look on the HCUP website. That's HCUP for Healthcare Cost Utilization Project. If you just Google HCUP US, you'll find all about our data and various tools. Next slide, please. What I'm going to be talking about today are the original comorbidity measures that we developed a number of years ago. Then I'm going to take a detour into a very simple chronic condition indicator, one of several tools that are freely available through HCUP, and that may be of use to you as you're looking at identifying comorbidities. And finally, I'll be talking about the development of indices that measure in-hospital mortality and hospital readmissions. So next slide. So a little bit of background on the original measures. Comorbidities need to be controlled when using hospital billing data, administrative data, such as HCUP and such as available from many of the states. And you can handle, it has been handled in the past in various ways, stratifying patients by having individual binary indicators for discrete conditions, or you can summarize the comorbidities into a single index or score. The Charlson Comorbidity Index really started it all in terms of trying to summarize information into a comorbidity index. That index, which was based on a group of breast cancer patients predicting one-year mortality, was taken by others such as Romano and Deo and widely applied to other populations and other outcomes. Please. Romano pointed out some cautions with using any kind of index like this, that you have to account for the complexity of ICD coding, that he suggested that weights should be estimated for different populations and different outcomes. I mean, I think there's some real disagreement about whether that should be done. We had a little bit of discussion about that earlier today. Another thing that Romano pointed out was that we need to ensure that the list of comorbidities is comprehensive. So for the 1998 study that we did, we developed and tested measures specifically with administrative data like HCUP, and we predicted in-hospital charges. Because these data are bills, what we get are the charges from the hospital to whoever's going to pay for it. Have ways of reducing those charges, adjusting them to provide an estimate of what it actually costs to provide that care. But what we get from the data are charges. We also did length of stay at that time and also in-hospital mortality. One of the problems with administrative data like HCUP is that because we don't have unencrypted identifiers, we don't have the ability to link the administrative data to death records, so that we can't get to a death index. So looking at the out-of-hospital mortality is not possible using HCUP data as it would be with Medicare data, for example. And what we did at that time is we looked at the development of measures overall for an entire state of data, as you'll see, and for selected diagnostic subgroups. Next slide. So you can break down illness burden into some basic categories. I'm sure there's many other wonderful ways of doing this, but this is just sort of what we were thinking about. You have the principal diagnosis, which is your primary reason for the stay. Okay. What we did is we wanted to limit our search for comorbidities just to secondary diagnoses. We didn't want to as comorbidities any conditions that really reflected the severity of the principal diagnosis. So what we did in our original work was to count comorbidities only if they were not directly related to the DRG for that patient. Also, didn't to count as a comorbidity any complications that resulted from care that occurred during that stay, so medical misadventures. So we excluded any ICD codes that would be, acute problems, possibly as a result of the medical care. We wanted to avoid any conditions that had a trivial impact on outcomes. So eliminated any comorbidities, potential comorbidities that were unrelated to charge length of stay and in-hospital mortality, and left us then with comorbidities that were not related to the principal diagnosis, but that had an impact on outcomes, that were not in the same DRG and that were not a complication. Slide. In terms of defining the comorbidity list, what we did is we a bunch of published studies, and we reviewed the ICD book, and we came up with a list of 41 comorbidities. We then did a series of analyses to find that list. We dropped those that were too infrequent. We dropped those that were statistically unrelated to outcomes. If a comorbidity was found to be very heterogeneous, we partitioned it further, and when some comorbidities that were weak when counted separately but stronger when combined, we combined those, and then we developed an algorithm to avoid double counting. So we only counted the more severe of two related comorbidities, and we came up with 31 conditions that we then continue to study. The study used 1992 data from the state of California. That was next slide, please. 3.6 million records from about a little over 400 hospitals. That database at that had 29 secondary diagnoses. We limited the study just to adults 18 years and older that were admitted to acute care hospitals, so we didn't include any long-term care hospitals or psychiatric hospitals. And we limited it to patients who were not transferred to another hospital because we wanted to have a stay that ended in discharge or death. Then we looked at all stays as well as 10 specific conditions that you see listed here. So the next slide, please. So the methods for the original measures, we used OLS regression, and we logged length of stay and charges. We used logistic regression for in-hospital mortality, and we controlled for age and race and payer and whether the hospital admission was an emergency admission or not, as well as complications that might have occurred during the stay. So next slide. We ended up then with 30 comorbidity measures that included conditions that hadn't been necessarily looked at before, like mental disorders and drug and alcohol abuse and obesity and weight loss and fluid electrolyte disorders. And we looked at their independent effects on length of stay, charge, and mortality. And because we generally used very large sample sizes in the analysis that we did with administrative data, we suggested using the measures as independent variables in models based on administrative data. So next slide. So over time, there was some subsequent development of those original measures. We decided to drop cardiac arrhythmias. It was found that those conditions were often acute complications that occurred during a stay. Other researchers have development, examining the use of present on admission indicators. These are indicators for every diagnosis on a record, whether that diagnosis present on admission or whether it originated during that hospital stay. And Stuckenborg looked at that. At that, it was only available from California and New York databases, and now it's available from virtually all states because it was implemented by Medicare a number of years ago. A couple of authors have taken our measure and have developed indices, found them to be valid substitutes for the individual comorbidity measures, and found them really to be a powerful way to condense comorbidity information. And the comorbidity measures that we developed have been to other outcomes as well, like readmissions. Many of these studies use small convenient samples, and that really was one of the reasons why we went ahead, a number of years later and continued development, which I'll describe in just a minute. We maintain the comorbidity software, and the website. It's, as I said before, if you just Google HCUP-US, the first part of the website name there, hcup-us.arc.gov, that is the website where we maintain all of the HCUP tools as well as information about all of the databases. It contains really all of the documentation that we have on everything that we develop. The tools are all available for free. We maintain them manually, adding new dossiers and procedure information when that's relevant. We've converted all of these tools to ICD-10. Those are also available now. Although we haven't yet received any ICD-10 data, we expect to get that probably early next year, February, March timeframe will be our first ICD-10 data. Next slide, please. So I wanted to just take a very short detour, a one-slide detour for something called the Chronic Condition Indicator. This is a really simple tool that we developed a number of years ago based on work that was done for the Medical Expenditure Panel Survey. What MEPS did was to put together a clinical panel that took all 3-digit ICD diagnosis codes. They used 3-digit ICD codes because that's all that MEPS reports in the Medical Expenditure Panel Survey. And this clinical panel designated each code as either chronic or non-chronic. What we did is we started with that list, and I continued to work with one of the clinical panel members to then expand that list, all diagnosis codes, up to 5 digits. And so I did a little screenshot here of the Excel file that you would get if you looked for the chronic condition indicator. And for each condition, ICD code, we have a designation of whether it's acute or non-acute. One is acute. Whether it's chronic or non-chronic. So 1 is chronic, 0 is non-chronic. And then we also just tell you what body system it's in. This is a comprehensive list of all ICD codes, and it tells you if it's a chronic condition or not. Also tells you which body system each code falls into. And, it could be the basis for, building your own comorbidity listings if you want to develop specific comorbidities for your patient population. There's other tool that I mentioned a little bit earlier called the clinical classification software. It's used, for example, by the Department of Health and Human Services Workgroup on multiple chronic conditions. This is the clinical classification software, or CCS, is another tool that's freely available on our HCUP-US website. I'm going to explore that a little bit and see if there's anything else interesting there that might help you in your research. Might also, I don't know what kind of data this group normally accesses, but if you're interested in any of our databases, you can find out about that as well. I'd be happy to, provide more information if anybody's interested in that. So let's go to the next slide. Let me just very briefly go over the current analysis that we're doing, where we're looking at mortality and readmissions. And what our purpose was here was just to develop comorbidity indices, again, for administrative data specifically. This is the HCUP state inpatient databases. We took data from the state inpatient databases to create this new HCUP product, this nationwide readmissions database. It's going to be released on Wednesday, where you can make national estimates of readmissions and revisits to emergency departments. You can track patients who are seen in the emergency department and then have a hospital admission, or people who are discharged from the hospital and then are seen in the ED, or patients who have ambulatory surgery and then who end up having to be hospitalized. I think it's going to have a lot of really interesting applications. The nationwide readmissions database, the one that's going to be released on Wednesday, I think, is actually going to be 2013 data. We used an earlier version of that contained 1,714 hospitals from 18 states, almost 11 million records, and it's drawn from states that contain basically about 45% of the population or hospital discharges. And the Nationwide Readmissions Database, or the NERD, as we definitely call it, includes encrypted patient linkage numbers so that you can identify readmissions. It's not possible to link it to anything outside of that database. The outcomes are in-hospital mortality. Again, we can't link to death records outside the hospital, so we're only limited to the in-hospital mortality, and we're looking at 30-day readmissions. With the nationwide readmissions database, you can do your readmissions period. You can make it 7 days, 14 days, 90 days. We just chose 30 because that's what's often used for the reporting requirements that we've got within our department. Next slide, please. So these methods that we used for deciding which comorbidities to include in our models. We used logistic regression using a maximum likelihood fit, and then we did bootstrapping, where we did 100 replications with 5% random samples, and then we did backwards stepwise regression. We also tested forward regression. There were negligible differences between those models, but we did this bootstrapping to see which comorbidities would appear in the final models. Slide. So these are the results of the bootstrapping. We set a criterion that comorbidities had to appear in 20% or more of the models in order to be included in the final model on the full sample. These are the comorbidities that we excluded based on this criterion. So the ones with the asterisk were dropped from the mortality models. You can see it's all 6 of these. And then the ones with the dagger, the last 3, the only ones dropped from the readmission model. Okay, next slide. So then in terms of creating the index, what we did is we took order estimates with significant effects, and then we assigned them a weight that was equal to the regression coefficient divided by the absolute value of the smallest regression coefficient, and then we rounded it to the nearest integer. And we did this so that, like, a comorbidity with a weight of 2 is twice as strong as a comorbidity with a weight of 1. It sort of make it into that way. And then we created the comorbidity index score, which was a weighted sum of each comorbidity variable in the model. We validated, next slide please, we validated here using a validation sample from the prior year. This is from 1,800 hospitals and 11 million records. And another type of validation that we did is we ran the model on the diagnostic subgroups that were based on the principal diagnosis that we grouped using the clinical classification software. I mentioned that earlier, about 250 diagnosis categories. And so we ran the model on each of those 240 diagnosis categories as well to see how things looked. We also did some analysis that I don't present here, broken down by sex and age and payer. I can describe those a little bit. It's just still in the works. But next slide. So here's a summary of the results. For the mortality model, we had weights that ranged from a -7 for drug abuse to 14 for metastatic cancer. And so negative means it's actually protective. And in models, we did not control for age because we assumed that age would be included in any model that is run by researchers who would be employing the index. So we didn't want to sort of double control. So it kind of makes sense. We didn't control for age. Most the patients with drug abuse were going to be younger, and so they are not going to have a lot of other comorbidities either. Less likelihood of dying, so that's sort of an explanation for why they would be protective. For the readmission model, the weights ranged from -3 for OB to 21 for metastatic cancer. I learned the comorbidities that had a protective effect, the ones that had negative signs. A number of these have been reported before. The hypertension has long had this protective effect in mortality models. And so here's the summary results for the performance on mortality. And I think you're going to have to click through these, yes. And so what we see here is that the index, the final mortality index, performed just as well as the 29 individual binary comorbidity variables. Okay, and but also comparable to results from other folks, Van Walraven and Thompson. So when we see that means that these measures are pretty robust. But if you use an unweighted count of comorbidities, some people have done that. I've done that before, where you just count up your comorbidities or you count up your chronic conditions. That really performs the worst. Okay. Now, if you go to the next slide, and again click through that, what we see here is that the index again performs as well as the individual binary variables, but it doesn't work as well as for mortality. Okay. Just a count of comorbidities does not seem to work as well. But the results with alternative weights were not as good. So, what this suggests is that it may make sense to develop weights specifically for the outcome of interest, because what Van Walraven did and what Thompson did is they used weights that were associated with the mortality model and a bit to readmissions. Okay, slide please. In terms of validation, we found very comparable performance on the 2011 validation sample. And then in the validation analyses where we looked at subpopulations for all the clinical classification software diagnoses, what we saw was that for principal diagnoses with the greatest number of in-hospital deaths, I just wanted to limit it to some subset, the C statistics ranged from about a 0.6 for stroke to about a 0.72 for pneumonia. So they were never as high as the full population model. And these are the kind of results that have led other researchers to say that maybe we should be developing weights for subpopulations, and that might be better to do separately rather than using one consistent index across all subpopulations. But Dr. Charlson mentioned earlier that a really good reason for not doing that is so that you can see how various subpopulations compare to one another if you're looking at this on a population level. And then in terms of readmissions, the C statistics ranged from 0.54 for schizophrenia to 0.63 for complications of device, implant, or graft. That 0.63 is actually the same as for the overall population model. In summary then, the next slide, the mortality index weights and the model performance were similar to previous studies that have taken our comorbidity measure and created an index of it. It was stable across a range of populations, and that the index performed as well as the individual comorbidity variables. To our knowledge, this is the first time that a comorbidity index was created for readmissions, and we found better performance than when you simply apply mortality weights to the readmission outcome. One limitation, and I didn't actually have a slide for this, but one limitation that I did want to mention here that we have to remember is that this is all based on administrative data, which have their limitations for sure. There was a recent study back in 2003, I think, by Garvin et al. And what they did is they compared the comorbidities that they found in administrative data to the comorbidities that were identified in medical records. And they literally found half as many in the administrative data than in the medical record. So this harkens back to something that Dr. Ash said earlier, that depending on how accurately your data are coded, some hospitals may code more heavily than others. This happened to be in a V setting where we're finding as many comorbidities listed in the administrative data than as in the medical record. Something that we need to keep in mind when using these kinds of data. So next slide, please. I said before, we've translated all of our tools into ICD-10 versions. Here's the URL for the comorbidity software. If you use just the URL, hcup-us.arc.gov, you can see our other tools and our data. Something that may be of interest is this group, depending on to what extent you use administrative data, is that we literally have hundreds of databases available over the years from multiple states, the national data as well. For research who are interested in looking at the elderly population, these are all payer databases, so it would provide you like a non-elderly comparison group. It also includes hospital stays for Medicare Advantage patients who, to my knowledge, are not included in the MedPAR files, and Medicare Advantage patients make up about 30% of the Medicare population right now. You would get those in the administrative data that we have available through HCUP. So that is the end of my presentation, and thanks very much for your attention.
Thank you, Dr. Elixhauser. I'd like also to thank all of our presenters today. We'll now move and continue our question and answer. Thanks to all of you who have submitting questions. Please continue to do so. We've received some through private chat as well as those that were submitted earlier. I think we'll jump into the questions, and some of these have been directed to specific lists, but others are open to everyone. Would love to hear all of your responses. For Drs. Charlson and Elixhauser, the question is, have you studied the incremental gain for cost-risk prediction in your index, Dr. Charlson, and your comorbidity algorithm, Dr. Elixhauser, when you combine data from both patient reports and claims?
I can answer pretty simply because I have only access to administrative data. I don't have any access to patient reports.
So generally, the comorbidity index is either calculated from patient answers to questions or medical record data or claims data.
Okay, thank you. Two presenters rating the various indices. Some people have commented that it's challenging, if not impossible, for healthcare providers to apply the indices directly to individual patients in the clinical setting to help inform clinical decision-making. Could you comment about application or inability, limitation of that application?
So this is Charlson. The patients can fill out a brief questionnaire. First of all, most of the conditions, at least in the comorbidity index, are in outpatient settings because they're major chronic illnesses. And, want to collect it uniformly on new patients, people can fill out a brief online or in-practice questionnaire. It takes 5 or 10 minutes to sit down and put in, or they can be sent links before their appointment before it is available at the time.
So this is Arlene. I have to say that there exist organizations that have put their data into computers and are capable of producing these scores, any score that's based on claims data, in particular the DCG scores, and have them available at the point of that the scores can be built on some claims history from the most recent year of information. So if you're talking about someone who's coming in January, you might be able to, have things through a few months ago, although I know of healthcare systems that actually can give you right up to date what is your score based on the morbidities that have been observed during the last year.
That you've got it at hand and that the patient has been followed largely in one organizational setting for a period of time. For example, people who are enrolled, new enrollment in Medicaid in multiple states, you have, no prior claims data on for the most part, or if you do, it's through a variety of safety net providers.
The power of the methodology is that it's a population-based tool, and to the extent that we do move towards accountable care organizations that are expected to know you, it's a valuable tool within that context.
Okay. I'm going to summarize the question here. We have multiple people in our audience that assess treatment effectiveness, and they want to know, what is your advice for assessing treatment effectiveness in multimorbid patients in terms of how you might define multimorbidity, how do your measurements and the research design? What advice do you have?
The problem with the term multimorbidity, as I said at the beginning, is that it means so many different things to so many different people. And, you find wide discrepancies in the reports of prevalence in any given population, depending on what elements are used. For studies of effectiveness, I like to look at like frailty, or including things like comorbidity, function as separate actual items rather than sort of lumping everybody together, because the actions may be quite different depending on what it is. So I found it a term in elucidating what works and whom.
It also depends on the type of data that you have available. And so that's probably a bigger determinant, at least from my perspective, if all you have is a claims database.
A tool like the DCG has the property that you can test the hypothesis that the kinds of outcomes that you're interested in are well described by the risk score. So you can just look at the population by increasing risk score and ask whether or not it is indeed true that as you move up in increasing risk score, that you have more of the outcome that you're worried about. And you can draw pictures like the ones that Charlson did for us. And in general, as you get people who have more comorbidities and more serious comorbidities, we're not talking, as Ann said, just adding the number of them. The more serious comorbidities you have, the more likely you are to have a bad outcome, and the more important it is that the outcomes that you actually achieve are contested with what you would expect given the morbidity mix of the patients that you're caring for.
Any other comments? I'll move on to the next question. Someone asked, if you were to apply all three of the methods or indices to the same database, for example, a care claims database, how correlated would your three indices be, and would the correlation vary greatly depending upon the outcome?
Anne, I have seen a study that compared. There have been, I think, a silly number of studies that have compared the Charlson and the Elixhauser measures, and I mean, from what I read, they're pretty comparable.
So one study quite a few years ago with CCS categories. So that's they're closely related to the Elixhauser score, and with the Charlson measure and with DCGs. It's a fairly old study. It's not the best version of anybody's model right now, but we saw real differences. But in terms of broadly speaking, they provide very similar pictures. They really do tell you who's sicker and who's likely to have more problems. The morbidity measures are pretty highly correlated.
Mm-hmm.
So it's one paper that we published in 2014. We've got some comparative, in terms of cost for those who are interested.
I'll say one other thing about different models and different weights, and that's, so if you have a single score and it's used for everything, it's going to have certain virtues, like you can interpret it the same everywhere, but it's not going to be able to tell you the difference in the implications in terms of a concurrent setting or a prospective setting. So DCG models have different weights for morbidities based on whether you're asking what are the implications of seeing that this year for the complexity and utilization and cost this year versus next year. For example, a woman is pregnant but hasn't had a baby yet has very different cost implications for this year versus next year.
Mm-hmm.
So the index was a 2009 comorbidity predicted 2010 costs. It also predicted 2009 costs and hospitalization. It was reasonably stable. There are differences, obviously, and price is probably the largest.
Final question, kind of combine a few questions that we've gotten together that talks about weighting, the fact that all morbidities aren't equal, such as end-stage renal disease, and an inpatient diagnosis code may not have the same weight as an outpatient diagnosis code. Have you considered creating any weighting systems in your models or indices to account for trying to target interventions that would have the high cost or high need in the future?
All methods are weighted.
Mm-hmm. And just to address the issue about using inpatient versus outpatient data, I mean the measures that we developed were all using inpatient data, but I've seen a number of studies that have applied to outpatient claims as well, and they were functioning pretty well.
I would caution against, looking at separately for inpatients and outpatients, because we're really dealing with chronic disease burden.
Exactly, yeah.
True that if somebody is hospitalized for pneumonia, they are probably sicker than a person not hospitalized for pneumonia, but mostly all of the systems have been designed to just record the fact that the person has pneumonia and think about the consequences of that.
Mm-hmm.
Come to the end of our time. We have so many more questions we're not going to be able to address. I wanted to thank you again for agreeing to give us this presentation. What a wonderful discussion. And Catherine, can you move to the next slide? I just wanted to ask everyone, and the webinar, if you could fill out our participant survey, and also to know there's a recording of this that will be available at the website. If you have any questions, please contact Catherine. Her email is on the screen, as well as you should have that in other communications. But again, I think you would hear a giant round of applause if everyone wasn't on mute. But thank you, Drs. Ash, Elixhauser, and Charlson, for participating in this webinar. We really appreciate it.
Very much. And I want to let you know that in lieu of applause, many people have sent in very nice comments